report and manage any public health threats. So how the IHR 2005 were born? Actually, the mechanism which triggered the birth of the IHR 2005 was the plague in India in 1994 and the SARS in Southeast Asia in 2003. These two events, the SARS, which caused from 30 to $1 billion as economic loss, and in India, 1.7 billion in terms of economics, in terms of tourism, in terms of transportation. International community suddenly was caught off guard. They realized suddenly that nobody was prepared to deal with such huge events, with such magnitude of public health events. So during the Health Assembly in 2005, the international community agreed upon adopting the new IHR. And when this is the documents of the IHR. It includes 66 articles, 9 annexes, and 10 parts. And it's a legally document. I had the privilege to represent my country, Morocco, in Geneva in 2005, and I was surprised that the majority of the delegates was either lawyers or ambassadors. So, and every full stop, every comma, every word was thoroughly discussed to be, it's very legal. So, let me just, okay. So, according to the IHR Annex 2, the purpose of the IHR is to prevent, to control any spread of disease, avoiding unnecessary interference with international traffic and trade. It means that WHO, when it comes to public health emergency of international concern, recommends through the IHR emergency committee provisional or temporary recommendations, and if any country want to implement additional measures, they should be scientifically based and evidence based to avoid any unnecessary interference, any harmful effect regarding traffic and trade. There are many differences between the 2005 IHR and the previous IHR, which is the 1969 IHR. The 1969 IHR was about the surveillance and the reporting of only 3 diseases: plague, yellow fever, and cholera. So it was very restrictive. Now the new IHR, the scope of the new IHR is wide. It's about any public health international threat, either infectious diseases, either radiological or chemical threat, food safety. So any threat, whatever the nature of this threat. So it's with a multi-hazard approach. So everything: chemical, infectious, zoonotic, biological, radiological, and multi-sector approach also. It means one government approach. All the sectors, all the involved sectors, including customs, transport, agriculture, tourism, all. It's not the matter of, it's not the business, the matter of the Ministry of Health only. It's a holistic approach. It's a matter of the all involved sector, all the ministries, all the departments. And there is with an emphasis on communication and coordination through the IHR national focal points. That's the novelties. There are novelties when we compare the previous IHR and the 2005 IHR. This IHR recommends implementing a certain number of capabilities or capacities within each country. The capacities are about legislation and policy to adopt the IHR and to adapt the national policy, the national legislation, be it decrees, be it ministerial decisions. So according to the specificity and according to the characteristics of each country, they should implement regulations in harmony with the IHR requirements. Also, the coordination aspects should be subject to MOE, Memorandum of Understandings, convention or arrangements between different ministries to improve the surveillance. The surveillance is a cornerstone in within the IHR, because when the country is if the country has a very sensitive and very efficient national surveillance system, any unusual event will be detected swiftly. The response, also the preparedness in terms of stockpile and emergency planning, the risk communications, the workforce or human resources, and laboratories capacities. So as I have said earlier, it encompasses all kind of potential hazards, including infections, zoonotic diseases, food safety, chemical, nuclear, and events at points of entry, also ports, airports, and ground crossings. And it's about the three levels of the country: national or ministerial level, intermediate or regional, community level, or local level. So regarding these capacities, the IHR Annex 1 discusses a lot in detail about these capacities. Capacities at national level, especially the surveillance side, about detecting, assessing, and applying health measures and notifying to the national surveillance system and to the IHR and WHO, and capacities at points of entry. Points of entry are airports, seaports, and ground crossings or land crossings. The base for the capacities at points of entry are the same. Still, there are some differences between airports, seaports, and ground crossings. But from the legal point of view, they have the same base. The same base is about activities, routine activities, which have to be performed on a regular basis, and activities to be carried out only in case of public health emergency of international concern. There are also aspects of coordination, international coordination, between the IHR national focal points. According to the IHR requirements, every country has to appoint, to select a national IHR focal point. Mainly it comes to the director of public health agencies like CDC or public health institutes. In Morocco, for example, the national IHR focal point is the director of the Directorate of Epidemiology. So, but keep in mind that the national focal point is not a person; it's the institution, it's the departments. Because one person can be absent, can be on holiday, so there are substitutes, and WHO deals with the institution. So how the WHO put in place some mechanism to information exchange, which is the event information site, which is a protected, secure site. The national focal point has access to this EIS through password. So when in case of a public health threat occurring in any country, so there is the steps are this event has to be rapidly detected, and WHO is alerted by the national focal point, and this event is assessed and evaluated through risk assessment, and then if and then the appropriate, the adequate public health response is triggered and implemented. So communication and information sharing are at the core of the IHR. There is a paradigm shift from the classical disease based epidemiology to event based all hazard approach. It means that WHO encourages member states to implement not only the classical indicator-based surveillance based on, for example, notifiable disease list, but also event-based surveillance and also syndromic surveillance. By the way, at points of entry, we utilize syndromic surveillance in case of epidemics of outbreaks to detect cases based only on the symptoms. We use also event-based surveillance based on rumors and information provided by other relevant and involved stakeholders, and indicator-based surveillance also. So we are living in a globalized world, and with an exponential expansion and growth of travel and trade. So, as you know, threats, public health threats anywhere is a public health threat everywhere, especially due to the development of air travel. So a traveler can go around the world in 24 hours, and a disease and viruses and bacteria don't know barriers, don't know borders, and don't need visa to travel from a country to another. That's why we have to put in place at points of entry mechanisms and procedures to detect imported vectors like mosquitoes, for example, and also the introduction of travelers carrying communicable disease, potentially epidemic communicable disease. That's what we call the global health security. So the institution of the national focal point is dealt with in the IHR Article 4, and the national focal point should be accessible 24 hours, 7 days on 7, to communicate with his counterparts at regional office, which is the WHO IHR contacts. So each WHO regional office has within the within WHA program or emergency program, the WHO IHR contacts who deals with all the national focal points in the region. The functions of these national focal points, which is a novelty, as I said, compared to the previous 1969 IHR, is to communicate nationally and internationally. So he has to notify in 48 hours all the relevant health events to his counterparts in the at regional office, and to respond to WHO secretariats regarding further information and further details about this event. And also he has to communicate within at a national level. For example, regarding points of entry, according to the IHR Article 4 and Article 22, the IHR local the IHR national focal point has to communicate with public health personnel and or public competent authority at points of entry when it comes to imported trade, when it comes to public health events at points of entry. So to have the information and to disseminate and to feed and to answer back to the public health at points of entry regarding what kind of public health measures has to be implemented. So the national focal points, and there is a network of national focal points all over the world. So, for example, during this COVID-19, the national focal points worldwide share informations about confirmed case and the contacts of confirmed case. For example, in Morocco, we receive on a regular basis through our national focal points the names of close contact to confirmed lab confirmed cases who traveled to Morocco based on information provided by national focal points outside Morocco. So it's a network of national focal point. This national focal point communicates with its counterparts at WHO regional office, with other national focal points, with the national system, national surveillance system, and with points of entry. The other novelty regarding this new IHR is, of course, the fake public health emergency of international concern. This fake is the only one who is entitled to declare public health emergency of international concern is the Director General of WHO regarding the IHR. This declaration is based on the recommendation of the IHR Emergency Committee. As you know, there are two committees: the IHR Review Committee, which discuss only the functioning of the IHR, the gaps of the IHR, the potential amendments of the IHR, and which issues standing recommendation, and the IHR Emergency Committee, which is convened by Director General when it comes to public health events, and which issues only temporary recommendations. So based on the recommendation of the Emergency Committee, the Director General of WHO might declare or not public health emergency of international concern. For the COVID-19, he agreed with the Emergency Committee and declared it as you know, as fake, as public health emergency of international concern. The decision instruments, as I said, the IHR includes 9 annexes. The decision instrument is the Annex 2 of the IHR, and through this Annex 2, it's decision instrument. Through this instrument, the emergency committee can decide if it comes to public health emergency of international concern or not. I don't know if you can see clearly the instruments, but it comes to 4 questions. Is the event unusual or unexpected? Is here. Is the event significant? Is there a significant risk of international spread? Is there a significant risk of international travel and restriction? So, is it serious? Is it unusual? Is there any significant risk of international spread? And is there a significant risk of international travel or trade? So, according to the answers to this instrument, it's kind of algorithm helping to reach a decision. So and it can be done at a country level also, and it is done also at ports when the public health inspectors go to the ships to inspect to carry out their inspection on different areas on the ships, and in order to issue the ship sanitation certificate. So it's very practical and very helpful instruments. So four diseases that always have to be notified are smallpox, human influenza caused by virus or SARS, and there are other diseases who will be will needing to use the algorithm, which are cholera, pneumonic plague, yellow fever, and viral hemorrhagic fevers, including Ebola, Lassa, Marburg, and others. So the four questions: is it serious? Is it unusual or unexpected? Is there any risk of international spread? And is there any risk of travel and restrictions? If the information is insufficient, there is a need to re-evaluate. So the event information site, which is a protected site used only by the IHR international focal point and his staff. So as I said, through this event information site, the national focal point reports to the IHR, consult and take advice from IHR, notify and verify any events before informing and before notifying his counterparts in the, at the regional office. WHO has, as you know, regional offices in Washington, in the Americas, in AMRO or PAHO, in Euro region, in Copenhagen, in Cairo, in EMRO, Afro region, South Asia, and Manila, Western region. And of course, the headquarters is in Geneva. So, as I said, the surveillance aspects within the IHR has to be performed at local or community level, at intermediate or regional level, and at national or ministerial level. It's about the early detection of any of diseases or death above expected levels, and to report the findings to the intermediate level, which is in turn will report this finding to the international level. If after confirmation, after assessment, public health measures can be implemented. So according to the nature and the causes of any public health threat, be it radiological, chemical, infectious. So whatever the cause, the appropriate public health measures has to be implemented. So the timeline of the implementation of the IHR. So it started in 2012. So with two extensions for the countries which not be which were not ready. But according to the second review committee of the IHR, this committee advised countries to implement which is called the IHR monitoring and evaluation framework, in order to evaluate and to assess the implementation of the IHR in countries. This IHR is made up by the external evaluation, the self-reporting or the state parties annual reporting, which is the mandatory part, action review and simulation exercise. So this IHR monitoring and evaluation framework is made of four components. So that's the legal basis of the monitoring and evaluation framework, and these are the four parts: the annual reporting, which is mandatory according to the IHR Article 54, the joint external evaluation, which has to be performed every 5 years, after action reviews performed after acute public health events, and simulation exercises on a regular basis. So regarding simulation exercise, it's worth noting that at points of entry, especially at airports, simulation exercises are mandatory because international airports are subject to the WHO and to IHR requirements, but also they are subject to the ICAO requirements. ICAO, which stands for International Civil Aviation Organization. ICAO is also a sister organization for WHO. It's a UN agency specialized in civil aviation, and ICAO has issues standards and recommendations, which is called SARP, standards and recommended practices. The standards are mandatory for the member states. The recommendations are only desirable. So according to ICAO requirements, each international airport has to put in place every 2 years simulation exercise, full-scale simulation exercise. Simulation exercise, there are 3 types, generally speaking: tabletop exercise, partial exercise, and full-scale exercise. So according to the IHR Article 47, as I said earlier, there is the review committee, which issues standing recommendation and amendments for the IHR, and emergency committee, which deals only with public health emergency of international concern and issues only temporary recommendations. The WHO selects experts from all the member states. There are 2 types of experts: IHR experts whose the names are provided by the countries, and experts who are selected directly by the WHO. From this IHR roster of experts, consultants or experts are selected to be part either of the review committee or part of the emergency committee. So it's based on the gender, on the geography, on the country, on number of the country. So there are conditions to be in order to be selected on an equal basis. And thank you. That's it. So if there are some questions about this first presentation regarding the IHR, questions, comments, or any demands of clarification.
Thank you, Dr. Mohammed. Can Dr. Mohammed hear us? Can you hear us, Dr. Mohammed?
Yes.
Okay.
I can hear you.
So thanks for that introductory overview of the whole IHR landscape. I'm always amazed by Dr. Mohammed's encyclopedic knowledge of all the articles of the IHR. But are there any comments or questions from the room, or from the audience? Nothing. So everyone's happy with the intro. Dr. Mohammed, can I just? Oh, sorry. There's one question here. Could you just introduce yourself and?
Hello. Okay. Yeah. I'm Dr. Kawai Patrick, volunteer at Africa CDC headquarters. Yes, so with the spread of COVID-19, we are seeing a lot of countries imposing restrictions in terms of movements. Now, what are the implications in terms of following the guidelines which are set by the international health regulations in that regard?
So thank you for this question. Actually, we are working with WHO on a new document, which is called the additional measures. Additional measures are measures that are implemented by WHO, and which, as if I may say, which are violating the IHR requirements and the IHR articles. WHO, in case of public health emergency, during the COVID, if you read the declaration of the emergency committee for regarding the COVID-19 or other previous public health threats, the WHO also urges and stressed the facts that no restriction for trade and travel should be implemented by member states. Unfortunately, many member states carried out ban, visa ban, or many passengers were during Ebola, for example, was quarantined at airports, and flights to affected countries were cancelled. But there is no evidence that such measures have an effect, an impact of regarding on the threat itself. Take, for example, Italy. Italy was the first country all over the world who cancelled flights and banned travelers from China. And look at Italy now. It had no effects at the number of the toll and the tally and the number of COVID-19 confirmed cases in Italy. So if you impose such bans, maybe you can have the contrary effects, not desired effects. It's not the main point is not implemented bans and be excessive in implemented in restricting travel and trade, but to strengthen its own public health system. In terms of surveillance, in terms of response, in terms of case management of the cases, and in terms of entry screening to early detect any case and to deal with it properly. So basically, neither WHO nor ICAO recommends these bans decided unilaterally, decided one-sidedly by the countries.
Thanks, Dr. Mohammed. Any other questions or points? Can I just ask, when are we expecting the minister? Is he coming imminently?
He's on his way. Our alert.
So how many?
You can go ahead.
We can continue, or we can.
Go ahead.
So just to come in on that previous question, I think the overreaction by many countries, and especially some very powerful countries, to the COVID-19 outbreak is going to have profound effects on the IHR in the future. Because while the IHR is one of WHO's only two legally binding regulations, IHR and the Framework Convention on Tobacco Control, between all its member states, enforcement has always been an issue because it's very difficult. WHO is not positioned to enforce IHR on member states, and really the kinds of measures that countries have put in place, banning people or enforced quarantine, all these kinds of measures has blown the top off the IHR, and we know now that countries will react in whatever way they think is in their own narrow self-interest, and that, in a sense, is what WHO had been trying to avoid. The grand bargain of the IHR was that if you report your disease outbreaks early and in a timely fashion, we will protect you from trade and travel restrictions, and that's been shown now that that doesn't really work in practice. So if you think about it, the implications are very profound for the future. China was a very powerful country with a lot of financial resilience, but if in the future you have an outbreak in a poorer African country or in some part of South Asia, which is, say, heavily tourist dependent, if you are the minister there, you will think 10 times before reporting the outbreak early now, because you know that I will suffer from the disease itself, but also my people will put in place restrictions and things like that. And WHO will, in a sense, be powerless to stop them. So we need to really think profoundly now how we deal with the issue of enforcement, how we can protect especially poorer countries if they do the right thing and report an outbreak early, either have some sort of disaster bond or some sort of financing option so that they can be compensated if people other countries put in place unfair trade and travel restrictions. I don't know what you think about that, Dr. Mohammed.
Yes, thank you for your answer. Actually, it's from a personal point of view, it's inherently due to the IHR itself. Compared to other legal instruments like the ICAO annexes and the ICAO Chicago Conventions, which was signed by all member states in 1943. For ICAO, for example, the standards and the requirements, ICAO requirements, are mandatory. If any airports all over the world doesn't comply, with this requirement, no airplane will came to this country, and you can imagine the detrimental effects and the harmful effects regarding economics, transports, etc. So it's mandatory. So all the countries, when it comes to ICAO requirement, they comply, because there are effects, there are sanctions. But when it comes to the IHR, there is no sanction. And even if you go to the IHR Article 3, it is said very very clearly that the implementation of the IHR, that the member states can implement the IHR in the framework of their sovereignty. So states have, in accordance with the Charter of the United Nations and the principles of international law, the sovereign right to legislate and to implement legislation. Since it's recent that there is a margin of sovereignty, so it's a loophole. So the member states, I'm not going to take advantage, but there is no sanction behind the properly and fully implementing the IHR or not. So as I said, I have said, the points of entry are a very important components of the IHR. All the 9 annexes are about points of entry, and more than the third of these documents is dealing with points of entry. So points of entry encompasses ports, airports, and ground crossings. And as I said, not only WHO is involved in at points of entry. There are 2 others UN agency: ICAO, International Civil Aviation Organization, for airports, and IMO, International Maritime Organization, for the seaports. So points of entry most of the time are located in international area, international zone. So and there are points of entry are subject to international regulations and national regulations. They are very specific in this regard. So according to the IHR, there is in Article 1, the IHR defines the points of entry as a means. Points of entry are means of passage for international entry or exit of travelers, baggage, cargo, containers, conveyances, goods, and postal parcels, as well as agencies and areas providing services to them on entry or exit. That's the definition of the points of entry in the IHR. So the purpose of the IHR, Article 2, is to prevent, protect against, and control and provide public health measures for international spread of disease in ways that are not commensurate, so no interference with international traffic and trade. At point of entry, and according to the IHR Annex 1, there are two types of activities. Activities to be performed on a routine basis, and activities in case of FACO, public health emergency of international airports. The ultimate goal of implementing IHR provisions at points of entry is to keep these points of entry free of any source of contamination or infection. That's the first and foremost goal to be achieved, to be attained. So risks should be identified and dealt with and contained at source. The golden rule when it comes to points of entry is to contain the risk at source. For example, when the COVID-19 arose in China implemented which is called exit screening. It means nobody will leave China before being screened at borders. In the contrast of the entry screening are the non-affected countries receiving goods and travelers from the affected country. So that's the main difference between entry screening and exit screening. And logically speaking, the best way is to start by the exit screen, containing all the risk at source within the country himself before spreading to other countries. The points of entry area are very regulated and areas due to this combination between international regulations and national regulations, and it's very procedural. Also, there are many procedures to be followed at ports and airports, and there are many shared documents between the IMO, International Maritime Organization, the ICAO, International Civil Aviation Organization, and WHO, the IHR. For example, the Maritime Declaration of Health to be provided by the ships to the health inspectors is shared by WHO and by International Maritime Organization. It's part of the IHR documents also. The Aircraft General Declaration to be provided by the pilots in command to the health authority is the same document exists in ICAO Annex 9 facilitation and the IHR. Many other examples, the passenger locator form, which is the personal information, the number of seats, etc. of the passenger who was next to any index case on board. The same document exists within ICAO regulation and WHO. So it comes to shared so agreed upon documents to be used at ports by ports authority and by ports operator, airport operator, and by public health authorities. So of course, this entry screening should be in line with the respect of the dignity and human rights of the passengers and of the travelers, as it's highlighted in the WHO documents, especially the IHR Article 3. And as I mentioned, so the IHR recognizes the sovereign rights of the countries to implement, but in line, in harmony with the IHR provisions. So as points of entry, or generally speaking, the IHR doesn't deal only with infectious diseases. It deals with all kind of threats, zoonotic diseases, chemical, radionuclear, infectious, whatever the kind of the threat. That's the main difference between the old IHR and the new IHR. Again, the same slide regarding the capacities to be put in place, including legislation, coordination, surveillance, response, preparedness, risk communication, human resources, and laboratories. I guess mainly all over the world, all the countries have experienced the GAE, Joint External Evaluation. Within the GAE documents, there are added capacities like immunization, like the countermeasures. So in the GAE, it comes to 19 technical areas. So again, this slide is very important. It should be really people working at points of entry should know this slide by heart, because it's the core of their work and their activities at points of entry. So routine activities and activities during emergency. Routine activities: access to appropriate medical services. This is the which is written in the IHR. What does it mean, appropriate medical services? I think that this item deserves some further explanation. For example, at airports all over the world, we can come across medical services under the authority of the Ministry of Health, medical services under the authority of the airports itself, the Civil Aviation Authority, which is which deals only with medical emergencies like heart attack, asthma. So nothing to do with infectious diseases or with communicable diseases. And we can come across also medical services which issued fitness to fly for the crew in the framework of aviation medicine, and medical services regarding the accidents at work, or occupational medicine. So and these medical services varies from one country to another. In China, for example, the competent authority in charge of implementing the IHR are made up of customs. The staff is under the authority of customs. In other countries, it's the Ministry of Transport. In some countries, there are foundations who are dealing with medical activities or sports. So, but every country has its own specificity and its own national regulations. But for the international organization like ICAO or WHO, it said the country. In Morocco, for example, at airports and ports, we have two medical services. Medical services under the Ministry of Health, which conducts epidemiological surveillance and public health activities, and another medical service under the authority of the Civil Aviation Authority, which deals with only pure medical emergencies. So it's up to the countries to decide what kind of medical services to put in place, and what are the interactions and the relationships between this medical services and the Ministry of Health. In Paris, Charles de Gaulle, for example, in France, the medical service is under the authority of the airport operator, which is ADP Aéroport de Paris, but it has a contract with the Ministry of Health. It's a memorandum of understanding, and it's a set of specifications. This medical services, which is a private company, reports to the Ministry of Health any public health threats according to the IHR. So it's up to the country to decide what suits it the best. The second item is the access of transport, which is ambulances. So the ambulances might be inside the tarmac, outside. Also the same thing, it's up to the country to decide. trained personnel for conveyance and inspection. Conveyance is mean the means of transportation. So inspection of when it comes to ships is very regulated. It's the issuance by the public health inspector of ship sanitation certificates. We have a presentation. We are talking about it in detail. For aircrafts or for airplanes, aircrafts in technical terms used at airports, it's the check of the aircraft general declaration. We will see it. So it's a document, and during the flight, if any medical or sanitary event happened, even the section of the aircraft, it should be written. It should be in this declaration and signed by the pilots in command and handed out to the public health authority at the airports of destination. The safe environment at points of entry, it's very important. It comes to conduct inspection at restaurants, at catering companies. Catering company are companies which provide meals to in-flight meals. And by the way, it's inspecting this kind of establishments is very different from inspecting regular kitchens, because there are rules, there are specificities. For example, the meals are chilled to less than 4 degrees before conveyed into the airplanes. Waste disposal, so the management of waste, of solid waste and liquid waste, and the vector control program within 40 meters of the airports, of the ports. So vector program is very important. In the scientific literature, there are many articles about airports malaria, for example. It's due to the anopheles transported on the planes and released at the airports, which many countries in Switzerland, in France, even in Morocco, people living around the airports was infected, had malaria, even that they have never been outside the country. So the vector control is about the monitoring of the insects, of the vectors, imported vectors through airplanes or through ships, and seeking out if there are alien or exotic species imported through these conveyances, which might multiply inside the airports, especially if there are breeding sites. It means standing water, pools of water, etc. So the main role of public health staff at points of entry is to eradicate these breeding sites and to monitor around the airports if there are new species, imported species, like the Aedes aegypti, for example, which is a very aggressive species, which can multiply at the expense of other local species. There are a brief overview about the routine activities to be conducted on a daily basis. When it comes to emergency like COVID-19, for example, the first and foremost requirement is to have in place a public health emergency plan. Public health emergency is very important, and this gap of the lack of a public health emergency plan as post-entry is one of the main gap reported by the outcomes of the GEE, the Joint External Evaluation, all over the world. So up between the ports for classical sections, including bomb alert, hijacking, fire on board, or fire at also. So it's the same template for all the countries. But the novelty after the adoption of the IHR is one section should be added to this section, which is public health emergency. So this plan should be tested through simulation exercise, and when it comes to public health emergency, it should be implemented. And it's and all the components of our airports are involved to help the public health authority at airports or ports to conduct properly the measures, be it entry screening, be it isolation, be it all this should be in line with the emergency plan. So these components of emergency plan, it's very important, and we have a presentation which will deal with emergency planning at points of entry. So when after the landing of the aircraft, there are measures during the flight before the landing, how to isolate a passenger, an index case, how the crew are the cabin crew are had basically a training about how to isolate communicable disease cases on board by isolating him, displacing the passenger, or displacing the other passenger sitting near him, and providing gloves and mask, and reserving one lavatory to this passenger, and collecting all the items touched by this passenger, putting them in a bag, in a biohazard bag, and dedicating one crew member to this index case. This crew member should protect himself by gloves and mask. By the way, all the international flights, all the international aircrafts have to be, according to the ICAO, three types of kits. First aid kit to be used by the cabin crew, medical kit to be used by any medical doctor or a health worker among the passengers, and and the third kit is about the communicable disease. It contains gloves, masks, apron, and dry powder, which turns out liquids into gel. So after the landing, parking should be dedicated to the aircraft, and the health authority, the public health authority at the airport destination, check the general aircraft general declaration. There is a separate place for interview for the passengers, and to assess if they have any sign or any symptom matching with WHO definition of the disease, for instance, with the COVID. And entry and exit control. What's that? Now you know the difference between entry screening and exit screening. You can use thermal cameras, you can use handheld infrared thermometers. So some airports have isolation room at the airport. Some other airports don't have it, and passengers had to be transported to hospital isolation rooms. For example, at Casablanca Airport, we have two isolation rooms, but one room with negative pressure. So it depends, and it's up to the country to invest, but it's a huge investment in isolation rooms and other facilities within the airports. So this slide is very important, practically speaking, for people who are working on site at airports or ports, because it's the same framework for ports and airports. Activities to be conducted on a daily basis, and activities to be conducted in case of emergency. That's really the basis. So what about legal basis of these activities conducted at points of entry with respect to the IHR? So any action like surveillance, verification, notification, we have the IHR article which deal with these activities. So article 5, 6, 9, and of course annex 1 and 2. It's the same thing for the points of entry core capacity requirements. The role of competent authorities are the authorities at points of entry or are in charge of implementing the IHR provisions. It's dealt with through the Annex 4, public health measures to be implemented, the correspondent articles, the health documents, we talks about it, maritime declaration of health at ports, and ship sanitation certificates at ports also. But for the aircraft, for the airports, it's the aircraft general declaration. Annex 5 and 6 deal with specific measures for vector-borne disease at points of entry. Also, all this legal basis, it's about activities to be carried out at points of entry, be it vector control, be it public health emergency of international concerns, be it verification, coordination, and communication.
So the role of the national the IHR national focal point will after verification, after assessment of the public health risks, and after discussing with the public health authority at points of entry, the threat is identified. It might be imported or exported cases, vectors, human cases, goods, contaminated goods. So the IHR national focal point should inform WHO within 24 hours. And of course, he keeps contacts with his counterparts in other countries. So we talked about GEE, Joint External Evaluation. Joint External Evaluation, the points of entry is a component of GEE. As you know, GEE is about 19 technical areas. Points of entry is one of them. And GEE, according to the GEE, countries should establish multi-hazard multi-hazard contingency plan, including for each point of entry. We talked about this emergency plan and we'll have a presentation about it. Improve animal quarantine capacity at points of entry, because at points of entry not only passengers are concerned, but also animals. And the international community remembers very well events related to contaminated animals, and to ensure systematic surveillance of vectors and reservoirs and points of entry. Of course, this multi-hazard public health emergency contingency plan should be tested through drills and simulation exercise to detect gaps and to detect dysfunctions. Two indicators for the GEE, again the same thing, the routine capacities, the first indicator, the second indicator is public health emergency. So routine daily activities and activities during public health emergency. For each indicator, there are 5 levels of capacities: low capacity, limited capacity, developed capacity, demonstrated capacity, and sustainable capacity. We have plenty of guidance and documents regarding points of entry. For example, vector control, guide to ship sanitation, and events management in air transportation and events management for ships and ports. We have one document regarding control
crossings. Everyone can subscribe, can register to this network. It's our network for people working at points of entry. We have lots of members from all over the world, and you are all invited to join us in this network. So just put PAGNet, and we'll have this page, and you can register.
Thank you, Mohammed. Your timing was perfect.
So thank you, Dr. Asman. As you know, the surveillance is very important, significant components of epidemiology and public health in general. As I have said, the IHR Annex 1 deals with surveillance at national level and surveillance at points of entry. So the scope of the IHR has been expanded from the surveillance of three specific diseases, which are cholera, plague, and yellow fever, to any illness or medical condition, irrespective of origin source, that presents or could present significant harm to humans. So, regarding the surveillance system, it has two goals, two objectives. The first one is to measure the disease burden, including monitoring some rates like the incidence rate, the prevalence rate, the case fatality rate, or morbidity rate. And the second objective is to early detect any upsurge, any significant change in the trends, any significant upsurge, any significant unexpected trend will trigger an epidemiological investigation to find out the causes of this sudden change. So there are other regulations actually regarding surveillance as points of entry. Regulations of the ICAO, International Civil Organization, especially Annex 9, 11, and 14, and air traffic management documents, which is called Doc 4040, PANS ATM, Procedure Air Navigation System Air Traffic Management, and Terrestrial Animal Health Code issued by the World Organization of Animal Health, which is the PVS pathway. It defines requirements of member states regarding surveillance and control of animal diseases. Is within each international airport and within any international seaports, we have staff from agriculture. So at airports, agriculture most of the time are located in the freight area, the cargo area, and it should be a close communication and cooperation between the agriculture side and the public health side at the airports. The methods for surveillance at points of entry depends on the points, on the nature, on the size of the points of entry, and of the fact if it comes to ports, airports, or ground crossing. So the data may be collected from the passengers, but also from other involved stakeholders like customs, law enforcement departments, immigration officials, airport operator, airlines operator, and service providers or handling providers. So there are different and numerous sources of regarding collecting the right information. So still, it's all over the world. It has been noted that there is a lack of workforce at points of entry to be able to tackle all the tasks and to collect information from other departments also. Anyway, this surveillance has to be multi-hazard and multi-sectoral focused and driven, collecting information not only regarding infectious disease, but also regarding biological, chemical, and radiological hazards. And as you know, importance and big size points of entry stands for the neck of the battle. Through points of entry, we have lots of goods, lots of different materials, lots of source, radiological sources, chemical products, agricultural products transiting from points of entry. So the staff of public health at points of entry has to play the role of investigators and of intelligence services, gathering any information regarding hazardous goods, and collecting information from all sources. So they are the eyes and the ears of the Ministry of Health at points of entry, because they are evolving in an unfamiliar environment, which is ports and airports. They are not at hospitals, at buildings and premises belonged by the Ministry of Health. They are in premises belonging to Ministry of Transport, and they have to deal with different stakeholders, and every stakeholder has its own priority. For customs, for example, is collecting duty and taxes. For security is security and other issue related to illicit behavior. For airports operator, it's running the airports. For the airlines and the ships is to come and to depart at on time. So having all these people around the same table and being able to sensitize them about public health issues, this the crucial and the important and difficult role. But he has to use the forums that we have discussed earlier, facilitation committee and security committee, because public health are parts and parcel from these forums. Ground crossing, we discussed this issue of ground crossing is the IHR Article 21, which stipulates very clearly that when it comes to the shared ground crossing, adjacent countries have to work together and to build together a common disease surveillance at ground crossing. So the source of information are very different and are various. Be it officers in command of ships or captains of aircraft, be it points of entry stakeholders, including veterinary services, agricultural services, customs, airport, civil aviation authorities, and other components working at points of entry. We have also the general public, travelers and travelers coming from connecting flights, and public health care services. I mean other services operating at points of entry and providing through contracts, through outsourced mechanism, healthcare. We have also documents, immigration cards, declaration forms, and information coming from the National Public Health Surveillance System, the IHR National Focal Point, and also information coming from other points of entry in other cities within the same country and in other from other countries outside the country. So all this information has to be correctly and appropriately aggregated and compiled and analyzed. And points of entry are parts of the national surveillance system. They have to feed on a regular basis the national surveillance system at information from points of entry and from the services are compared in order to detect any unusual, any suspicious link between them and to trigger the epidemiological investigation. At points of entry, we are using indicator-based surveillance, event-based surveillance, and syndromic surveillance also. We in order to collect the best quality of information, we rely on communication, collaboration, coordination, and communication. These are the four C's. The four C's used in civil aviation with other sectors at points of entry and with public health, subnational, regional, national, and international level. We have to use the early warning system and the alerts and the response. And we have to go, when we send suspected cases, for example, we have to receive the feedback from the Ministry of Health regarding the laboratory results, regarding the tests. For example, when we detect suspected case of COVID at airports, we have to be informed about the results from the Ministry of Health. So, what is the desired impact of following implementing good surveillance system at points of entry is to be able to identify events of concern, of course, and to enhance national and intermediate level and national level in terms of analyzing data coming from points of entry. So as you can see in this slide, when there is a signal, whatever the source of the signal, actually at points of entry, we perform three linked activities. The first one is the risk management. The risk management, if you remember, the activities that we perform on a regular basis, the routine activities. Through these activities, we can pick up from time to time signal. The signal can be very little at the beginning, but they can grow and become more and become stand for danger. So we start. That's we call risk management. If the signal is significant, we perform risk assessment to measure and to evaluate the potential consequences of the signal. If the signal grows again and grows bigger and stands for real danger, we perform event management. So we trigger the emergency plan. So more or less, roughly, these are the three pillars that we conduct at points of entry. Of course, we back to the slide. If a signal is detected, it has to be verified, assessed, and notified to the national focal point. The signal is detected through indicator-based surveillance and through event-based surveillance, of course. So that's why we are talking about intelligence, epidemiological intelligence at points of entry. What is the rationale behind this? It's the fact that communication is critical to ensure that events are detected at points of entry and the timely response is conducted. The information sharing is the key to the early warning, alerts, and response. And as you can see, we talk so a lot about the role of the IHR national focal point. This table discusses in detail about the legal reference, which is the IHR article, and the functions of the national IHR, national IHR, national IHR at the central level, which is a notification request for verification, and events information system, which is the site at WHO that's only the national focal points can access to through password. So, and the tasks of his counterparts at the regional, at WHO regional level. So there are the list of the functions, as you can see. The algorithm for the Annex 2, we discussed about this algorithm also. Is the public health threat is serious, and is it unexpected or unusual, and does it stand for a danger for the international spread of the disease? Finally, the difference between the event information system and the DON, which is the event information system is protected by a password. Why the disease outbreak news? It's part of the public domain. It can be accessed through the WHO websites by anyone. Just put DON and you will have all the information about ongoing outbreaks all over the world. This is an example of the page. This is how it is displayed. for events information system. And this is an example of the dawn of the disease outbreak news, which is accessible to everybody because it's already in the public domain. And thank you.